Now, Prof. Andrew Hill, anastomotic leak in colorectal surgery, early detection. Is it possible? Please.
Shukran. Thank you very much for inviting me. We've had a great time, our team from the International Society of Surgery, and it was good yesterday to sign the MOU. If any of you are interested in joining the International Society of Surgery, please feel free to talk to me or our Secretary General, who I think is at the back there somewhere behind one of the poles. We'd be very happy to guide you as how to go about it. Otherwise, you can do it on the web. I'm going to talk about something this morning that, of course, I've never seen myself, but many other surgeons have, and I'm sure that we all feel that way. Anastomotic leak is one of the things we're all. This is not going. Do I use this? Not moving. Anastomotic leak is one of the most feared things in colorectal surgery, and reported rates vary. Results in morbidity, death, and apparently related to tumour recurrence in some cases. A philosophical question that might come up in this kind of talk is, are we actually aiming to predict an anastomotic leak, or are we detecting an anastomotic leak? And I hope as I go through this talk that you'll remain as confused about that question as I am. So when we are the main aim is actually really to detect an anastomotic leak as clinicians. Predicting it would be helpful too, but often the prediction happens at a time when we can't do much about it. If we could predict it preoperatively, obviously that would make a difference to what we did in surgery, but the usual thing is the situation of detecting it in the very difficult situation after an operation. So what things do we have in our toolbox? Well, we have clinical signs and symptoms, we have radiology, we have an inflammatory marker, CRP, C-reactive protein, which has got a lot of press, and I'll talk a bit about that. A variety of biomarkers, which in this case and inflammatory mediators, which in this case, as opposed to in the last talk that was mentioned, may in fact be of some use. The question is, how do we use these tools to help us in clinical practice when we're rung at 3 in the morning by a junior doctor who's trying to tell us that one of our patients has had a terrible complication? What sort of things can we do that might in fact help us? So here's a table that enables, here's a website you can go to, anastomoticleak.com, easy one to remember, that helps you to get some idea about predicting an anastomotic leak beforehand, and it may help you to make some intraoperative decisions. For instance, you may decide that the patient on balance should have a stoma, or maybe you'll choose not to give the patient an anastomosis at all. In the case of maybe a person who's got sepsis or a person who's very malnourished, you may in fact just give them a stoma, in which case an anastomotic leak doesn't come into it. But the holy grail is diagnosing an anastomotic leak prior to a disaster. Now currently, most of us use clinical symptoms. So a patient that's abdomen is, again, is very difficult in the post-operative period, but may in fact have peritonitis. CT scan can be quite useful, but is expensive and plainly not something you want to do if you can avoid it, and often is not available in the middle of the night in some of the smaller hospitals, may involve a transfer. The patient, of course, may or may not be very sick. There are anastomotic leaks that don't show up very much early on, but become a big deal later on. It's quite a variable course. Patients who've been involved in a perioperative care program may have a blunted stress response, and sometimes we use statins, steroids, non-steroidal anti-inflammatories, all of which may mask and of course the way we use our analgesia may all in fact mask things. And then of course the complexity between laparoscopic and open, and the clear differences between colon and rectum and their anastomoses. So it's very difficult and challenging to know exactly what to do. So is there hope? Is there something that can give us some clear ideas as to what we should do? And there's been a lot of talk in the last few years about biomarkers, and I hope to make this a little clearer as we go along. So C-reactive protein is the one that's had the most news. It's a serum marker of inflammation. It has a relatively short and constant half-life. So, you know, what it was today is not the same as it's going to be tomorrow, because the half-life is less than a day. So it's a relatively useful real-time test. An increase seems to precede clinical signs of infection, and is it a detector of an anastomotic leak? And the problem with it is a good sign of infection, and there are many infections that occur after surgery that aren't an anastomotic leak. So here's a systematic review that we did, and as you can see, most of the studies were retrospective. Moderate sized number of patients, very large retrospective study over 12 years from Warsaw in Switzerland. And you can see that there were a lot of different things they were looking at. So you can see but the range of elective surgery ranged from 76% to 100%. Cancer, again, was about half of the patients through to all of the patients. Open surgery, this was a largely open surgical era, and in some parts of the world that's not so relevant now. And the leak rates were very variable, ranging from a low of 5%, which is what most of us sort of accept as kind of what we think a colectomy leak rate should be, through to quite high figures such as 16%, suggesting some issues maybe with technique, or perhaps with judgment, or perhaps with inclusion of some patients maybe they shouldn't have. And the leak rates across the study is 5 to 16%. The pooled prevalence of leak on average was around about nearly 10%, and the median diagnosis of leak was actually relatively late, 6 to 9 days, suggesting there may have been some issues of selection bias in these patients, or perhaps some patients should have been excluded. This is what a normal CRP looks like after surgery from these studies, and you can see that it rises from at the time of surgery through to a peak about day 2, and then starts to fall off over time. If a person has an anastomotic leak, you can see that actually there's a quite early departure of the CRP from normal, suggesting something going on quite early after surgery. And you can see then it peaks around about day 3 or 4, and then starts to fall off a little bit. And usually the patient has had something going on at this stage. Or in fact, it may fall and then rise again. And in this study, as I said, the leak rates were a little bit, where the leaks happened quite late. But you can see the divergence from the normal thing between days 2 and day 6. It is consistently different. The problem is, if you superimpose a person who has, say, a pneumonia or a urinary tract infection or even a wound infection, you can see that the difference isn't that marked until quite late in the piece. So when you've got a high CRP, it may in fact be due to something else brewing or something else going on other than an anastomotic leak. But now I've told you that CRP goes up after an anastomotic leak. You know, the house surgeon or the registrar calls you and says that the CRP is 200 on day 3, you're still going to lose sleep over it, even if the person has a pneumonia. Now, one other way of looking at things is to do what's called cut-offs and also area under the curves. Now, the area under the curve is I won't go into it in detail, but an area under the curve of over 0.7 is quite a good test. An area under the curve of 0.5 equals the test is not very good at all. So here we have some area under the curves for days 3, 4 and 5, 3 at the top, 5 at the bottom for CRP. So we can see that a high CRP on days 3, 4 or 5 is actually quite a good test for an anastomotic leak. The cutoff scores are a bit strange, that they actually get higher on day 5 than they were on day 4. But if a patient has a CRP of over 140 on day 5, you probably want to be a bit nervous about what's going on with them. But here's the problem. The negative predictive value, in other words, if the CRP is under that number of, on day 3, 172, the negative predictive value is 97%, and it consistently goes across that. So in other words, if the patient, if you're worried about the patient and the CRP is lower than these so-called cutoff values, then there's a high chance the person doesn't have an anastomotic leak. But positive predictive value of the test is actually very low. So if the actual figure is over that number, then the positive predictive value is only about 20 to 23%. So it's a test that's what we call a rule-out test, not a rule-in test. And this is something many people forget and don't fully understand or apply. So CRP seems to be a very useful, it seems to be a relatively useful negative predictor for an anastomotic leak. We use it in our institution as a guide to a safe early discharge. So if you are sending patients home after colectomy on day 3, 4 or 5 and the CRP is low, then you can be quite confident, well not totally, but quite confident that the person doesn't have a leak. But if the CRP is high, our practice is to keep the patient in until it's a little bit lower, just because we're a bit nervous about it, but it doesn't mean we suddenly do a CT scan or a laparotomy. Now here's another test that's done from somewhere in Australia where they looked at CRP trajectory. So this is where you actually looked at CRP rising by more than 50 units per day. And under those circumstances, this is an area under the curve of 0.96. That's actually quite a good test, although in subsequent work it's been shown it wasn't quite as good as was hoped. In our own study we've just completed now with 350 patients, didn't confirm it was as useful as we thought it would be. But it had some promise. And in the individual patient, as opposed to groups, which is many of these studies have been done, this in fact might be quite a useful test. So if your CRP was 120 and today it's 170 and the next day it's 220 or 30 or so on, then that's something you need to be worried about. That's quite a good sign, and those people should have some kind of intervention, probably a CT scan. The way we've looked at this is by looking at what we call the perianastomotic environment. So our hypothesis is that there's actually a relatively small leak quite early on before the big disruptive leak happens, and that should produce a number of different things that leak into the area around the anastomosis and then into the bloodstream. And there's a whole bunch of these. There's some bacteria, there's a variety of ischemic markers, seeing that most of us think that an anastomotic leak is probably an ischemic phenomenon. So immunological markers, a number of cytokines and growth factors, and some inflammatory markers such as CRP and procalcitonin, things that are relatively non-specific for inflammation. And we've used this to do our own study. So we recruited. So the first study we did was we'd done some prospective studies before, and we looked back at those from in about 200 or so patients, looking at plasma and peritoneal levels of a variety of different cytokines. Now the peritoneal, the plasma ones were collected just by taking a blood test and then spinning the blood down, but the peritoneal ones were taken by having a little drain in the peritoneal cavity and using that to suck off fluid. Now that drain, we're never quite sure if it's near the anastomosis or not because they move around, but we put the drain in specifically to measure peritoneal cytokines. And then we looked at these area under the curve for receiver operating curves, receiver operating characteristic curves that I was talking about before. So the 200 patients with complete cytokine data, their anastomotic leak was a little high at 8.3%, but we found that levels of peritoneal IL-6 and IL-10 on day 1, so that was the day after surgery, this was from the little drain from the anastomosis, were actually relatively predictive for an anastomotic leak with reasonable area under the curves and quite highly significant statistically. Plasma cytokine levels of IL-6 were high on day 1 than those who didn't, but it wasn't a very good predictor. So actually taking fluid from somewhere in the abdominal cavity, looking at the so-called perianastomotic environment, actually seems to be a reasonably useful test or predictor. This is looking at plasma cytokines. You can see that they're all around about 0.5 to 0.6, so not really much use. This is looking at drain cytokines on day 1, and you can see, as I said, that interleukin-6 is actually quite a good test. So the take-home message from that study was that something appears to be going on quite early, and that peritoneal or drain levels of a variety of different of a couple of cytokines at least may actually be reasonably helpful in making, and these being the kind of patients you might want to watch a little bit more closely or do a relatively early CT scan on. There's a whole variety of these markers that have been looked at. I won't go into detail. This is a very long list and very boring. But you can see there's a variety of them that have been used that have shown some utility in other studies. So, but again, all of them, CRP, procalcitonin, white cell count, sodium, calprotectin, fatty acid binding protein, and a variety of other cytokines are all reasonably good at negative prediction, but again, are non-specific in that they don't help with positive prediction. We've recently completed a study of over 300 patients, as I said, and many of our results really were, it was a little disappointing that these studies were just similar to they were similar, and we had some other cytokines we measured, but again, interleukin-6 and CRP were, again, once again, very good negative predictors, but not particularly good at positive prediction. So, as I said before, we have good negative predictors. They're not very good positive predictors, but it may be, and we're still analysing this as I speak, there may be some promise in combinations of biomarkers that more accurately reflect that peri-anastomotic environment that aren't the same, say, from pneumonia or urinary tract infection. So the take-home message about an anastomotic leak and using blood tests and others to look to help you. First of all, it seems that something is going on as soon as day one in a patient who will go on to develop an anastomotic leak. And that's very interesting and does suggest that the ischemic insult happens very early and is just covered up by all of the other things that go on. In fact, not infrequently, these patients will be ones that present with an ileus that goes on for a little while, and a CT scan will be very helpful to look at why that might be. We're not there yet with detecting the leak. It seems to be an adjunct to clinical suspicion and perhaps a guide to the use of radiology investigation. CT seems to be the most useful one in colon surgery. CRP and inflammatory markers are currently useful in predicting safe discharge, and so that's the way we use it. If the CRP is below our local cutoff value for CRP, then we're happy to send the patients home early, but if it's high, we will keep them or we might CT scan them. That's roughly the way we use these tests. CRP velocity, that's where the CRP is going up quickly, might be of some value, and there may be some value in looking at ratios of different kinds of cytokines. And then I think probably these tests are useful to help us guide us as to the use of imaging as these inflammatory markers change with time. Hope that's helpful to you. CRP is something that's very confusing to a lot of us, and I hope this has cleared it up for you. Thank you very much.
Thank you very much, Professor Hill, for this distinguished, realistic, applicable lecture. It carries a lot of meanings, and a lot of things should be put in the mind for all surgeons performing such type of surgery. We can make just a couple of questions before the prayer time is coming. Okay, Professor Ortega.
Well, as you know, prophylaxis is better than treatment. What I do regularly, when there is an instance of leakage, for example, anterior section or orthotopic urinary bladder, I drain the 4 quadrants of the abdomen from the beginning. I put 2 silastic drains in the right flank, 2 in the left flank, and silastic tube, 2 silastic tubes in the pelvis, so that if leakage occurs, I don't have any problem. I will wait until it heals. And so there is no problem. I don't open any patients again, and it is my policy, and I am satisfied.
Well, far be it for me to criticise a very senior surgeon like yourself. The use of drains in the peritoneal cavity to detect an anastomotic leak or to treat an anastomotic leak is not generally accepted as being very effective. But I have heard people like yourself say that, and there must be some truth in it somewhere. But generally, my approach for an anterior resection is if there's, or a high anterior resection, for instance, if there's any evidence or anything that worries me about it, those people get defunction with an ileostomy, and those people don't keep me up at night anymore. So I think, you know, one of the things that happens is that when you're looking at a series of patients, you need to look at their defunctioning rate, because that will make a big difference as to what their leak rate will be, certainly their clinical leak rate. And so some people will have very low rates of anastomotic leak, but actually very high rates of stoma formation. So there's lots of different variables on this. The drain hasn't been proven in everybody to work, but for some people, yes, I've had many anecdotes along those lines.
Yes. Well, in colon surgery, do you insist on ileostomy, or there is now a trend that you don't do any decompression with colon surgery? What is the available knowledge about that?
So most of us don't. You mean drain? So there's a few things that
defunctioning ileostomy,
So,
whatever.
yeah, most of us wouldn't defunction a colectomy. I think there are certain situations in which you might. And it's generally if there's something about the whole thing that's just not quite right. So there was a lot of hypotension during the operation. There was a lot of bleeding. Maybe there was a contamination. Maybe the person's malnourished. In those circumstances, you might want to bring out an end stoma, or you might want to defunction. But it's not my practice and the practice of most to defunction colons. When it comes to rectums, that's another story. I personally defunction all of them. I know that some people don't, but I think they're very daring, and I'm not one of those type of people. But colons generally not.
Professor Khalid?
Thank you, Andrew, for your presentation. And one of the crucial points to prevent the leakage is the vascularity. To maintain the vascularity, it needs some good maneuver, some good techniques, and so on and so. And to detect ischemia or to prevent ischemia, do you have any experience about the use of endocyanin E? Because nowadays many societies put it in the guidelines also.
So no, I have no experience of using indocyanin green. There's certainly some people that have. I wonder myself if the ischemia happens at the anastomosis itself, as opposed to once you've done the anastomosis. Obviously, there's some technical things you can do sometimes that will lead to an anastomosis. It seems there's an obligate level of somewhere between 3 and 5% that just leak whatever you do, no matter who you are, whatever you are. And those who report less are probably defunctioning more or are being dishonest. And those who have higher leak rates, maybe there's some technical issues there. But yeah, this indocyanin green hasn't found its way into routine practice for most of us, but I know that some have used it.
Thank you very much. It's time of the day. Thank you. It's the end of the session.